बिस्मिल्लाहिर्रहमानिर्रहीम रब्बी शरह ली सदरी व यस्सिर ली अमरी वहलुल उक़दतम मिन लिसानी यफ़क़हू क़ौली अल्लाहुम्मा इन्नी अस्अलुका इल्मन नाफ़िअन रिज़्क़न तय्यिबन व अमलन मुतक़ब्बला शिफ़ा मिन कुल्ली दा. This is Dr. Zunaira Faiz, gynecologist. The topic of discussion is malignant diseases of the uterus. Incidence. Endometrial cancer accounts for approximately 30% of all the gynecological malignancies. The lifetime risk of developing cancer is approximately 1 in 90. The incidence of endometrial cancer rises sharply in the mid-40s. 25% of the cancers occur before menopause. Etiology. The exact causes of endometrial cancer remain unclear. However, there is clear association with high circulating levels of estrogen. Important risk factors are obesity, diabetes, nulliparity, late menopause, unopposed estrogen therapy, tamoxifen therapy, hormone replacement therapy, family history of colorectal or ovarian cancer. In this risk factor, the diagram which shows about the obesity, nulliparity, PCOS, polycystic ovarian syndrome, diabetes, HNPCC stands for hereditary non-polyposis colorectal cancer syndrome. And then is the age. Types. The most common types of cancer affecting the uterus is adenocarcinoma. There are two different types: endometrioid adenocarcinoma type 1, serous papillary carcinoma type 2. In addition to endometrial adenocarcinomas, malignancy can arise from the stroma myometrium sarcoma. In types, if we see type 1 endometrioid adenocarcinoma, it accounts for 90% of cancer. They are estrogen dependent, occur in young women, have good prognosis. Type 2 cancers occur in elderly and are non-estrogen dependent, have a poor prognosis. Pathophysiology. Endometrial cancers are divided into two classes, each with differing pathophysiology and prognosis. Type 1 endometrial cancer, the most common class due to unopposed estrogen stimulation resulting in a low-grade histology often found in association with the obesity. Type 2 endometrial carcinoma, estrogen dependent, occurring in older women. Clinical features. Abnormal vaginal bleeding, 90% present with either post-menopausal bleeding or irregular vaginal bleeding. In perimenopausal women, common symptoms are intermenstrual bleeding, blood-stained vaginal discharge, heavy menstrual bleeding, lower abdominal pain or dyspareunia. In advanced cases, patients may present with evidence of fistula, bony metastasis, altered liver function or respiratory symptoms. Signs and symptoms. We can see unusual vaginal bleeding, spotting or discharge. It will lead to the dyspareunia, pain during sexual intercourse. Then dysuria, painful micturition, and pelvic pain. This is so pain and pain and pain. Diagnosis, examination. Bleeding may be noted arising from the cervix on speculum examination. Bimanual examination of the uterus may reveal an enlarged uterus. Investigations, ultrasound and transvaginal scan, endometrial biopsy, hysteroscopy and MRI. Ultrasound, transvaginal ultrasound, findings suggestive of endometrial cancer. Endometrial thickness more than 5 mm, hyperechogenic endometrium with irregular outline, increased vascularity with low vascular resistance, intrauterine fluid. It can be performed in the outpatient settings or inpatient with anesthesia. It also directs visualization of whole endometrium and allows fluorescein biopsy to take place. Biopsy. Endometrial cancer can only be diagnosed by histological examination of a biopsy. Endometrial biopsy can be performed using pipette. The histological report should give information on cancer type and grade. Following biopsy, MRI is often performed. This gives information about extent of disease. A catheter is inserted into the uterus through the vagina to remove the cells from the uterine lining for examination. This is endometrial biopsy, and this is how we insert inside the uterine cavity. Staging. Figure staging is used in description. Type Stage 1. Tumor confined to the uterus. 1A. Less than 50% invasion of the myometrium. 1B. More than 50% invasion of the myometrium. Stage 2. Tumor invades the cervical stroma but does not extend beyond the uterus. Stage 3. Local or regional spread of tumor. Stage 3A. Serosal or adnexal invasion. Stage 3B. Vaginal or parametrial involvement. Stage 3C. Metastasis to pelvic or para-aortic lymph nodes. Stage 3C1. Pelvic lymph node involvement. Stage C2. It was stage C1. Stage C2. Para-aortic lymph node involvement with or without pelvic nodes. Stage 4. Extension to the pelvic wall. Lower 1/3 of the vagina or hydronephrosis or non-functioning kidney. Stage 4A. Invasion of the bladder or bowel mucosa. Stage 4B. Distant metastasis including the abdominal or involvement of the inguinal lymph nodes. Here you can see in this is the yellow color shows the endometrial cancer growing and how it is increasing and spreading. Stage 2, stage 3, and then 3C, 1A, and this is 4A, 4B. In usually the last stage, it is also associated with the metastasis. And usually I teach to the students that LLBB, liver, lung, bones, brain. When the metastasis go to the liver, lung, and bone, brain, it is usually in the stage 4. Management. Surgery. Surgery is the most common treatment for endometrial cancer. The extent of surgery will depend on a number of factors including grade of disease, MRI stage, and patient's comorbidities. Standard surgery is total hysterectomy, bilateral salpingectomy. If patient is low grade or MRI staging suggests less than stage 1B, then this is adequate. If cervical involvement, radical hysterectomy with pelvic lymph node dissection can be performed. Adjuvant treatment we have to give. Post-operative radiotherapy will reduce the local recurrence rate but does not influence survival. Local radiotherapy to vaginal wall or external beam radiotherapy can be given. Chemotherapy may also be given for metastatic disease to combat the risk of distant spread. Management includes the surgical, radiotherapy, chemotherapy, and palliative. In surgery, total abdominal hysterectomy with bilateral salpingo-oophorectomy, pelvic washings, and lymphadenectomy and omentectomy. Radiotherapy, external beam, and vaginal brachytherapy. Chemotherapy, carboplatin, doxorubicin, and Taxol. We add combination of these medicines. Palliative, hormonal therapy, radiotherapy, supportive therapy. Prognosis. The overall 5-year survival rate is 80%, stage 1 88%, stage 2 75%, stage 3 55%, and stage 4 only 16%. I added this slide just to show you that this beat the baby who was born twice. Nigerian surgeon Dr. Olinka Olitio and Dr. Daryl Cass cut a woman baby out her womb at 23 weeks old, successfully operated on the baby after taking out a tumor. Then placed the baby back into the mom's womb, and the baby was later delivered healthy and naturally on the time at 36 weeks. Sarcomas of the uterus. These are the rare tumors and account for approximately 5% of all the uterine cancers. They are classified into pure sarcomas, heterogeneous sarcomas, or mixed epithelial sarcomas depending on tissue type present in histological specimen. The most common are carcinosarcomas or leiomyosarcoma. The uterus is often enlarged and soft on palpation. Preoperative diagnosis is difficult but may be aided by MRI which can delineate areas of necrosis within fibroid. Surgery is the main treatment, and adjuvant therapy may be considered if count is high. Assessment. What are the risk factors associated with the endometrial cancer? What are the symptoms with which a patient of endometrial carcinoma presents? What diagnostic modalities are available for diagnosis of endometrial carcinoma? How do you stage endometrial carcinomas? With that, thank you. Everybody has talent, but ability takes work hard. I hope my lecture will freshen your knowledge. Jazakallah khair.